This is Natalie Conish with my case study, part 1. 55-year-old white male patient is prepping for his annual colonoscopy. His GP discusses with him the preparation before getting a colonoscopy and goes over his PMH and FH. He finds that his father's doctor found malignant cells had formed in the tissues of his colon. In addition, polyps were found. The patient's father was diagnosed with colon cancer. The gastroenterologist performed a total colectomy on his father to remove the malignant cells. The patient's doctor told him that it is very important to receive a colonoscopy annually since his father had colon cancer. He tells his patient before the procedure he will need to cleanse his colon of toxins. He suggests he take a laxative to cleanse the colon and not to eat anything for 24 hours before the procedure. The morning of the colonoscopy, the gastroenterologist uses a colonoscope to examine the colon. He finds that there are no signs of any malignant cells or polyps in the colon. The patient's brother drives him home. While the patient is home resting, he starts to feel anxiety, lightheadedness, and tightness in his chest. The patient's brother called for the EMTs to take him to the emergency department, and the RN takes his vital signs at 11 o'clock. His temperature is 99.2, pulse 100, blood pressure 140/90, and respiratory rate 24. The RN calls the MD along with the PA to review the symptoms. The RN attaches electrodes to the chest of the patient. The electrodes are wired to an EKG. On the EKG, the MD finds only a few P waves and finds that the heart is beating irregularly. They find that the patient's heart is in atrial fibrillation. The MD comes back every few hours to check the EKG machine. On his third trip, he looks at the EKG machine and finds an elevation of the ST segment or an ST elevation myocardial infarction. The MD quickly takes the patient to the catheterization lab. The RN puts an IV in the patient's arm. Again, electrodes are placed on his chest and wired to an EKG machine. The MD uses the femoral approach to insert the catheter and introducer sheath, which were threaded through the arteries of the heart. The cardiologist then injects the contrast material through the catheter into the arteries of the heart, which outlines the heart's vessels, valves, and chambers. The cardiologist finds there is a blockage in the heart. He takes out the catheter and performs coronary bypass surgery. After the patient recovers, the cardiologist finds that the patient's heart is still beating irregular. The cardiologist discusses the option of putting in a pacemaker to help regulate the heart. The patient agrees.